How is that? How do you like that?
Beautiful.
Beautiful. Good. Gorgeous. I like that word even better. All right, so we are in the 60 plus actually. So 49 out of 76 match. That's what I call a pretty good rate, isn't it? So probably this is for all of you a good indication where to put, some of your money. If you ask me, how do you stop, the automatic thing? I'm a very transition. Is it transition? Must be. Slideshow. Record, rehearse, no. From beginning. All right, how do I stop the show? It's not a show because I need to spend on some slides more. So how do you stop this? Any idea? Escape. Then
What is it automatically moving?
I think so, yes, because this was given, or part of it was given in the by E.
Where is No, there is no search there.
Okay, so but why is it flipping, on its own?
I don't think this is.
Maybe
I
it's your
think-
hand. Maybe. All right, let's hope that it does not. Okay, so we are going to be talking about the liver. I guess you have went over the physiology review with Dr. Ahmed this morning. It is doing this, so it is doing this, yeah. Anyway, so let's talk about, the hepatic lobule, which is the functional unit of the liver. Very importantly to know actually where is the central zone of the hepatic lobule, thank you, and the periportal zones of the hepatic lobule. I think it should be okay. Let's hope. Thank you. Appreciate that. All right, so the periportal zones. Now, one thing you need to know, I did not. One thing you need to remember is that the area number one, which is the area that is closest to the periportal, to the portal triad, that is area one, or zone one, which is the area most close to the portal triad, is the most oxygenated and the most supplied by nutrients, by the fact that actually the hepatic artery and the portal vein are actually located in that region. Now, the zone in the middle of the lobule is actually the zone number 3, which is the pericentral zone, surrounding or around the central vein. It is the area that is most distal to the portal triad, and that makes it actually the area that is least oxygenated. Not only this, actually, it is the area that is most rich with detoxification enzymes, detoxification systems such as the P450. So as a result of that, whenever there is an ischemic event, whenever there is a toxic event, this area is going to be affected. All right, zone number 2 is in the middle, so it goes halfway between the two of them. All right, so now you see actually the 3 zones that we have talked about: zone number 1, followed by zone number 3, and zone number 2 in between. Now, between this, so this is actually the zone 1, 2, and 3 are in the hepatic lobule. They are made up of hepatic cords, the hepatic cords. And the hepatic cords, as you know, are actually 1 or 2 cell thick. They are, designed by the Almighty as 1 or 2 cell thick, so that is going to ease actually exchange between the hepatic cords, between the hepatic cells, the hepatocytes, and the hepatic sinusoids, where the portal and the hepatic artery, the portal vein and the hepatic artery blood mixes. So it has direct, what you call, connection to the hepatocytes. Now, the first layers of cells that separates the hepatic lobule from the portal tract is what you call the limiting plate. So in reality, there is no such thing actually as limiting plate. It is a theoretical division. But the reason why actually you're using it or you're creating this theoretical imaginative division is because a lot of times there are cells in the portal tract that are inflammatory cells in the portal tract, that are present in normal circumstances. Now, the number of those cells become actually a little bit more than normal. The question is, do you have inflammation or not? Do you have what is known actually as a portal triaditis or not? One of the ways, actually, this is how old pathology used to, do it. One of the ways, for you to say that there is a real inflammation is when you start to see that those inflammatory cells that are present in the portal tract are now crossing over into the hepatic lobule, crossing over the limiting plate. Okay, so this is why actually you create this, imaginative kind of structure that does not exist. There is no such thing. There is no barrier between the hepatic lobule and the portal tract. Simply, it is a mark, actually, if you will, to tell you that now you probably, are having a true inflammation that is engulfing the the hepatic lobule. Now, that's one. The reason why is that important is that most acute inflammation starts in the portal tract. And that is pretty logic, because that's where you see, the blood is. So this is where, if there is any kind of viral infection, is going to be brought there. If there is any kind of bacterial infection, any parasitic infection, is going to be there. So that's where you start to see, those inflammatory cells are going to actually be also brought to the same site in order to fight the ensuing infection. All right, and once it spills over into the portal tract, so acute inflammation that is going to be focused on the portal tract, when it starts actually to cross over, the limiting plate and into the hepatic lobule, what you call, hepatic lobule inflammation, that's actually when it starts to become chronic. So I want you now to think about it like this. Of course, there are a lot of gray zones, and you see that, in terms of inflammation, there are bouts of inflammation that happen in someone with, chronic hepatitis. So you will see what you call acute superimposed on chronic. But for the most part, I want you to remember that acute inflammation starts in the portal tract, whereas chronic inflammation or chronic, entities, are going to be focusing on the hepatic lobule. All right, so now let's talk about, what happened to the liver when it faces an injury, when it faces a damaging, event. Luckily, the liver is going to respond to this damaging event in the same way. It does not matter if it is ischemic, if it is metabolic, if it is infectious, whatever kind of infection it is. At the end of the day, the liver cell, the hepatocyte, is going to respond in the same way. So let's talk about actually if there is, an infection. Let's say that there is actually a form of a viral infection that is going to be delivered, that is going to come from, the blood and end up in the liver. If it's an hepatitis A, it's going to come from the GI. If it's hepatitis B or C or D or G, it's going to be coming actually in the blood and delivered to the liver. Now, what's going to happen, there is what we call, viral effect, and there is also, that's going to be related to the inflammation effect that is going to happen at that site. So, for example, let's talk about hepatitis B. Hepatitis B actually infects. Hepatitis B virus infection, infects the hepatocytes, and it actually does a number on, the liver cell. We'll talk about that as we get to it. But the main, actually, the destruction that is going to happen to that hepatocyte is going to be, also coming from the inflammation that this, infection is going to, make develop, that is going to, make happen. So, necrosis is going to follow because, when you bring into the site of action cells of inflammation, at least in the acute stage, that's in the form of neutrophils or macrophages. Those cells have the oxygen, dependent mechanism, and those cells are going to actually simply destroy everything that is present there. Now, degeneration is another form of injury that may happen to the liver cell. Degeneration in this case is maybe actually taking the shape of accumulating a certain metabolite in the liver cell itself, such as glycogen, for example, or fat. Eventually, as fat, as innocuous as fat was actually thought to be, we know now actually that the fats, the fatty infiltration, the microvesicular steatosis that happen in liver cell may actually result in a rupture of this liver cell. And when this liver cell ruptures, it's going to create inflammation that is going to be actually resulting in the formation of a granuloma, and that may eventually result in fibrosis and cirrhosis. So it starts with simply, accumulating of a metabolite and ends up, doing this. Sometimes degeneration happens because the liver cell is involved in a very hectic kind of process. For example, biosynthesis. Biosynthesis, on the average of far above normal. Example of that, what you see, for example, in hemolytic anemias, with all this, bilirubin that is being brought to the liver to become conjugated. The liver cell, in this case, is going to be working overtime, and that may result actually in its degeneration. Toxic injury, for example, we can talk about actually iron accumulation, increased iron deposition in the liver that may happen either as a result of secondary causes, such as what happens with, when the life of someone becomes dependent on multiple transfusion, such as, in those very hard to treat kind of anemias, such as thalassemias and sickle cell anemias. The patient is dependent on transfusion for the rest of their life. The iron that is coming with the blood is going to end up actually in the liver cells, resulting in its degeneration. Now, inflammation, as I mentioned to you, remember those types of division. Of course, the division, the disease does not read the book, and you see a lot of overlap. So, for example, let's talk about hepatitis A. With hepatitis A, it is mostly a portal triaditis because it is an acute inflammation, but you see a lot of actually crossing over the limiting plate. So you see periportal inflammation, and you see also, lobular inflammation as well. And the same goes actually for those, chronic inflammation, chronic infections such as hepatitis B and hepatitis C, where you see that the main action is in the lobule, but there is still, some remnant inflammation in the portal tract. Now, the other actually part of this is the type of cell that is involved in the process. We know that lymphocytes and plasma cells, the chronic inflammatory cells, are what you see with hepatitis B and hepatitis C. Now, with hepatitis A, there is, plasma cells exclusively. We know that, for example, with alcoholic hepatitis, we see actually the neutrophils that are going to be there, the star of the action, if you will. Regeneration, one of the great abilities of the liver that we know about is its ability to come back from the dead. You take, 7/8 of the liver in surgical kind of, categorization, and you leave 1/8 of the liver intact. This liver is going to come back to normal, will grow back to normal. So it is one of those tissue that is actually a stable tissue. It will only divide when it needs to divide. So you take it out, it will come back. Now, again, it's a double-edged sword because this incredible ability to regenerate may also actually be a very hazardous kind of finding in cirrhosis. So in cirrhosis, the liver cells are going to try actually to limit itself from the rest of the liver environment. Why? Because of an ischemic event, because of a toxic event, because of an infectious event. And it does that actually by simply creating those regenerative nodules, those nodules that are surrounded with very thick collagen. Now, in the process of doing so, it protects actually the cells that are present in those regenerative nodules, but at the same time, the anatomic, structure, the anatomic / functional structure that is present between the hepatic cords and the hepatic sinusoids will be lost forever as a result of that, at least in this hepatic nodule. Okay, so the end result is going to be that those cells, unfortunately, are going to die because they no longer have access to, the nutrients and the blood supply that is present in the hepatic sinusoids. Fibrosis is going to follow actually any kind of injury, and this fibrosis actually may be intense. So, for example, let's say that the process started with portal triad inflammation. Eventually, if it's limited to the portal triad inflammation, and if this, inflammation or this infection is of a special type, it may end up actually in fibrosis of the portal tract. I'm saying a special type because we know, for example, that hepatitis A, even though it starts in the portal triad and cause portal triaditis, but eventually is going to be resolved completely without any kind of sequela. There will be no fibrosis that will follow. The only thing that you would worry about from hepatitis A is simply that it may result in fulminant hepatitis and it may kill the patient in a very small minority of patients. But for other, for example, in other type of infections such as B, C, D, and G, you may actually see that, the inflammation is going to be followed. The inflammation that will accompany the infection is going to be followed by actually fibrosis. And this fibrosis may start in the portal tract, and then it may actually start to, quote unquote, bridge. It will start to connect with nearby actually fibrous foci, if you will, creating what you call a bridging fibrosis. And we will see how this bridging fibrosis happen and what will it result in now. So cirrhosis is what you call an advanced actually level of fibrosis. That's when you have actually, let's talk about, an infection such as hepatitis B or hepatitis C, which is more likely actually to result in chronic inflammation. That is going actually to be affecting the portal tract first, and then it will spill over into the lobule. So in this case, you will start to see that the portal tract are going to undergo inflammation, and this inflammation eventually is going to heal, and it's going to heal by fibrosis. Now, this process is happening all over the liver. So you will see that the adjacent actually portal tracts that have become fibrous will start to reach out to each other. First, in the form of inflammatory cells, what you call a bridging inflammation or a bridging necrosis that will follow the inflammation, and then eventually bridging fibrosis. When you start to see that this process is going to engulf, a whole number of portal tract that that are adjacent to each other, the end result is going to be the formation of a hepatic nodule. You see that? So again, let's go back to this. First, you have portal triaditis, right? That's going to be followed by portal fibrosis. And then those inflammatory cells will start to reach out as they spread, as they quote unquote spill over the limiting plate, they will reach out to nearby portal tract. So that's what you're going to be calling bridging inflammation. And then those cells that are in the cross path of those cells, of those inflammatory cells, will die out. And that's what is going to be called bridging necrosis. Eventually, everything is going to get fibrosed. So you will start to see, first the fibrosis of the portal tract, and then those septa that are going to be, sent out from one portal tract to the other portal tract are going to become organized. They are going to create a bridging fibrosis. So all these bridges that you find here are going to surround this amount of liver cells. It looks like a nodule, and it is a nodule, okay? So that's actually what you're going to be calling hepatic regenerative nodule. It is regenerative because it is done actually to preserve the liver cells from the effect of the infection by simply isolating the liver cells in this nodular structure, if you will. But in the process of doing so, it's going to add more harm than injury, more harm than good, actually, as you will see. More insult and more injury to the structure of the liver. As you can see, pathologists have a sense of humor. So this is a horrible regenerative nodule that has the shape of the heart. You see that, right? Okay, so you can see actually that this fibrous tissue here surrounds this fibrous nodule from all sides. Where did this fibrous tissue come from? It is actually the result of the bridging necrosis that healed in the form of fibrosis. And you guys know actually the process, right? So there is inflammatory cells that will be, first there is injury in the form of a viral infection, in the form of ischemic event, in the form of a toxic event, toxin deposition. That's going to be, what's going to happen as a result of that? When you have a sentinel event, then you will start to call to action the inflammatory cells, right? So you'll be inviting the inflammatory cells, the neutrophils and the macrophages. What will especially the macrophages be producing? The macrophages will be producing other actually markers, other cytokines that are going to be inviting the fibroblast to the site of action. So after the fibroblasts start after the macrophages start their cleaning action, their janitorial functions, if you will, they are going to be asking for this tissue that get lost to be repaired. How does it do that? By producing the cytokines that will be first, activating the, what is equivalent to a fibroblast in the liver, as we will see. And two, it's going to invite actually other cells from the blood, the fibroblast to the liver to become organized and to lay down this very thick fibrous tissue. All right. So portal hypertension. So what is that? What is portal hypertension? Again, one of the what you call the garden variety kind of response to liver injury. Portal hypertension, the most common cause is cirrhosis. So what happens in cirrhosis is that the liver becomes full of fibrous tissue. Now imagine actually the liver is receiving this portal blood from the GI. And this portal blood, pressure is pretty low. So, and it has one way, which is actually into the liver. What happens when the liver becomes actually full of this fibrous tissue? It will create resistance to the flow of blood. Actually, this fibrous tissue is not simply like the cell of, the main cell that is causing this fibrosis in the liver is not simply a fibroblast. It is a myofibroblast. So this fibrous tissue has ability to contract, which is even going to add actually more, insult to injury, and is going to result in more resistance to the flow of blood into the liver. Now, there are many other causes of portal hypertension. How about actually instead of a liver cirrhosis, there is a thrombus in the portal vein? How about that? Will that do the same? Pretty much the same, right? So portal pressure, portal tension is going to increase. How about actually if you have something like a Budd-Chiari syndrome or hepatic venous thrombosis, what used to be called suprahepatic veins, thrombosis of the suprahepatic veins, or actually now we call it hepatic veins thrombosis. So this is actually what drains the liver, right? If those veins that drain the liver are actually blocked, are thrombosed or blocked, what is going to be the result of that? The same result exactly going to happen. You have increased actually the pressure in the portal, circulation, and as a result of that, there is portal hypertension. Now we'll talk about actually how that come to happen, because once the flow, of blood into the liver, have slowed down, what's going to happen actually to the rest of the blood that has to have its way? That's actually when you start to see the areas where there is anastomosis between the systemic and the portal circulation are going to take over. Those areas are going to be receiving more blood, are going to allow more blood in order to accommodate this, retrograde flow, if you will, of blood into the GI. Okay, so as a result of that, you will start to see, for example, there is, varices at the level of the lower esophagus. Okay, and there may be actually also, there may be also, there may be also some kind of hemorrhoids, between, at the level of the rectum, and also at the level of the umbilicus, what is known as a caput mediosa. Now, at the same time, actually remember that this also, all the tributaries come from different regions. So the blood will also go back into the spleen, resulting in splenomegaly. Okay, as you know, the spleen is the master organ in terms of inspection of the blood cells. So one of the ways that this can happen actually in the spleen is because of the very intricate relationship of the splenic cords. When the spleen undergoes, enlargement or hypertrophy, the end result is going to be that some of those cells are going to become entrapped in the spleen, especially the platelets. So the more severe the splenomegaly, the more pronounced the thrombocytopenia. Okay, the more severe the splenomegaly, the more pronounced the thrombocytopenia. So now we know actually this is one of the indications to show you how pathology actually contribute to clinical medicine. One of the signs of the severity of the cirrhosis is by going and looking at the number of platelets. Okay. Now another thing actually that happened. So now all this blood is pulling up in the GI, right? So now what's going to happen is that there is a lot of bacteria that may actually start to grow, and these bacterial products such as the nitric oxide. What does nitric oxide do? Vasodilation. So now you have actually an NO that is being produced and is not being cleared because of the the blockade, if you will, at the level of the liver from whatever cause, thrombosis, cirrhosis, Budd-Chiari syndrome. And the end result is going to be that with this vasodilation, there is going to be more increased actually flow towards the liver, and that is going to increase or worsen the portal tension. All right, here's a beautiful actually picture, courtesy of osmosis. We have to give credit where credit is due, as you can see. These are the hepatic cores, as you can see here. Hepatic cores, as I mentioned to you, is made up of 1 or 2 cells thick. The reason for this is that its intricate relationship with the hepatic sinusoids. When it is free, it's going to be manned by an interrupted layer of what is known as the ITO cells. ITO cells. And as a result of that fact, you will see that there is a free movement of blood and also of nutrients, bilateral free movement of blood and nutrients between the hepatic cord and the sinusoid. Now, what's going to happen, let's say that there is some kind of injury that resulted in fibrosis. One of the main areas of fibrosis that is very important for the pathophysiology of liver cirrhosis and portal hypertension is the area beneath the portal, beneath both the hepatic sinusoids and the hepatic cords. This area here, the area between the two. Why? Because the moment that it becomes filled with this very thick fibrous tissue, which does not exist in normal condition, and that starts actually to pressure the sinusoids nearby, what happens to portal tension in this case? It's going to increase as well, okay? Now, as I mentioned to you, these cells are not simply fibroblasts, they are myofibroblasts. So they will not only actually be there physically, but they are going to compress, and when they compress, they are going to further actually increase the amount of, of pressure inside the portal circulation. All right, hepatocellular carcinoma. Hepatocellular carcinoma will happen as a result of chronic inflammation from whatever source. At one point in time, we thought that fatty liver is simply a very benign condition. Now, actually, fatty liver is going to be the new hepatitis C in the US. In the 90s, late 90s, early 2000, we thought that the highest number of hepatocellular carcinoma, hepatic failure and hepatocellular carcinoma was going to come actually from hepatitis C. Now we know that this is not going to be the case. Why? Because of the obesity rates in the US, and what is going to happen is that fatty liver, which was thought to be a benign condition, now is known to be actually the harbinger of hepatocellular carcinoma after it turned into a non-alcoholic steatohepatitis, the NASH, non-alcoholic steatohepatitis, and that eventually is going to result in chronic inflammation, is going to result in fibrosis, cirrhosis, and finally hepatocellular carcinoma. So you will see that cirrhosis for a lot of the entities that are going to precede actually the hepatocellular carcinoma is going to be there. But it does not need to be there. For example, if someone has hepatitis B or hepatitis C to a level probably a little less extent. So what's going to happen is that the virus is going to become integrated into the liver cell genome. And that's actually how it will become, how the cell becomes transformed, giving rise to hepatocellular carcinoma in the absence of cirrhosis. This is especially seen when there is something known as vertical transmission. What's a vertical transmission? Mother to fetus during actually the pregnancy or during delivery. Where do you see that in the world? Do you guys know? Usually in Asia, in Southeast Asia, you see the kind of vertical transmission where hepatitis B is still actually, still a very formidable, enemy in that region. So what happened actually as a result of the fact that it's a vertical transmission, the baby, the newborn, it did not really develop, all the immune mechanism that are going to allow them to establish, fibrosis, inflammation and fibrosis, and then eventually cirrhosis. But the virus itself will find its way into the liver cell, and that's actually how the liver cell becomes transformed, giving rise to hepatocellular carcinoma in the absence of cirrhosis. Here's an example actually of hepatocellular carcinoma arising in a background of cirrhosis. So this is actually two nodules of transformed cells, of cancer cells. The rest of it is probably simply a regenerative nodule. Now, one of the features, as you will take that with Dr. Imad, inshallah. So you will see that one of the features of the of hepatocellular carcinoma, a lot of times it's really very hard diagnosis, especially when it's a small biopsy. One of the very important feature is the number of cords, of hepatic cords. Imagine how important is that as a structure and also as a criteria for the diagnosis of hepatocellular carcinoma. It will be far more than 3, 4, and the more. All right, so now cirrhosis development involves three processes: death of the hepatocytes, extracellular matrix deposition, and vascular reorganization. Now, the extracellular matrix deposition is a very interesting one because in normal condition, in normal state, if you will see that the capsule, the portal triads, and the area around the central vein have collagen types 1, 3, 5, and 9. Now, between or below, actually beneath the normal hepatocytes, there is no true basement membrane. Instead, there is a delicate framework of collagen type 4. Interrupted layer of collagen type 4 that is laid down by these ito cells. What's going to happen when, so let's talk about the process of inflammation and fibrosis and eventually cirrhosis. So you will see that, there is a maestro, like you guys have seen that in the bone where there is, the osteoblast. What time is it, guys? Do you want to take a break or? Let's do another 5 minutes and then maybe we can take a break. All right, so you will see that a cell, that is going to act as, as the maestro of this process. In this case, it's going to be the Kupffer cells. The Kupffer cells are the ones that receive all kinds of signals: ischemic signals, metabolic signals, toxin signals, infectious signals, and it's going to respond in the same way pretty much. So you will see that it's going to, release chemotaxis factors such as the MCP1 and the PDGF, the platelet-derived growth factor, and just one second, monocyte chemoattractant protein. All right, so monocyte chemoattractant protein 1 and the platelet-derived growth factor that are going to attract actually more platelets, are going to attract other inflammatory cells to the site of damage. It will also produce something known as E2-1 or endothelin-1 that is going to actually incite those cells to contract. So it will work on the myofibroblastic ability of these ito cells. It will also produce TNF and also PDGF, tumor necrosis factor and PDGF, that are going to make those cells proliferate and organize. So now, instead actually of the interrupted layer of the type 4 cells, you're going to see a much thicker layer of fibrous tissue in this region. Now, this fibrous layer now has actually blocked the reach of the liver cell into these hepatic sinusoids, and as a result of that, you see that these liver cells are going to die, in this case by apoptosis. Okay, so again, that's going to be the same kind of process, regardless of the insult that is happening. Ischemic, toxic, infectious, it does not matter. It will always reply in the same way, resulting in exactly the same process. All right, so the clinical syndromes of liver disease, starting with cirrhosis. What causes it? Pretty much everything. It is the end result of so many different processes, infectious, and if it's the type of a chronic viral infection that is affecting the liver, such as Hep B, Hep C, it's going to end up in cirrhosis in a good number of cases, depending on what type of infection the patient is having. If it is mechanical, if it is ischemic, if it is chemical, it's all the same. It's going to result in the same exact result, the cirrhosis result, where the liver is made up of, has been divided into regenerative nodule as a result of the fibrous septae that are crisscrossing the liver from one end to the other. So this is one thing actually I forgot to mention to you. So instead of the type 4 collagen that was actually manning this region, the very thin layer, interrupted layer of type 4 collagen, once there is injury, the ito cells will start actually to produce the type 1 and 3 collagen. And that's a very thick type of fibrous tissue that is going to block completely the reach of the liver cells into the hepatic sinusoid. So remember, from type 4 to type 1 and 3, the switch happens when there is a damage to the liver. All right, so activated Kupffer cells, but there are actually other cells that may also play as maestro of this process, including the sinusoidal endothelial cells and also damaged hepatocytes that may produce some of these factors. All right, so talking about also pathogenesis of cirrhosis, two major vascular lesions, including the loss of sinusoidal endothelial cells fenestrations, so a development of portal vein, hepatic vein, and hepatic artery portal vein shunts in the fibrotic bands. So those are going to be actually there, and they are going to be under pressure from the fibrous tissue that is surrounding them. Here is an example of a normal liver structure where you see this interrupted, very what you call wispy layer of fibrous tissue that is type 4. Compare that to here, actually, when you start to see that, the fibrous tissue that is now present in cirrhosis between the hepatic cords and also in the membrane surrounding the regenerative nodule is going to be of the type 1 and type 3 as a result of the switch that I mentioned. All right. Another clinical syndromes is portal hypertension, increased resistance to the portal blood flow. We did talk about the different types of causes of this syndrome: prehepatic, hepatic, and posthepatic. We talked about each one of them. Now, the pathogenesis, we'll do this and we can stop. Pathogenesis of portal hypertension in cirrhosis. So the level of the sinusoid is very important as a result of the fibrous tissue that will be pressing it. 2, compression of the central vein by increased fibrous tissue. And 3, anastomosing and shunting that happen in the fibrous bands. And finally, another important cause is actually the release of the nitric oxide from the bacteria, the gut bacteria, that now is not getting cleared as a result of this blockade of flow. This is an important thing to remember, the mechanism of the portal hypertension. Okay. All right, we'll stop here, and then we come back in 5-10 minutes. Thank you very much. All right, guys, so we have talked about all of this. For those of you who like to see pictures, I don't think a lot of you like that, right? So this is the opposite. This is for the figuratively challenged, or for the text challenged people. If you like to look at it, in a picture, it's right here, and again right here. Okay. So that's going to take. Actually, before that, last thing is liver function test. You will see different schools of medicine telling you different things about liver function test. Some of you, I should have asked you first actually before going to this slide, but we can do it for the sake of time. You will hear people telling you it is ALT, AST, alkaline phosphatase, other enzymes of the liver, and those are simply enzymes. They don't look at the function of the liver. So when you talk about liver function test, you need to assess every function of the liver. The best panel that is followed in the US is this 4-test panel, 4-test simple panel. Bilirubin. So bilirubin is going to look actually at the level of the synthetic capability of the liver of bile. You have the ALT and AST are going to be the enzymes in the hepatocyte, so it will tell you about the integrity of the hepatocytes. The prothrombin time, that is going to actually look at the synthesis ability of the liver of so many different clotting factors that are part of the coagulation cascade, and albumin. So each one of them is going to be actually important indication of how the liver is doing. One question I want to ask you: when you go and measure, when you go and look at the blood work of a patient, and you see the ALT and AST, and you see that the ALT and AST have what you call a normal value in the blood. If you open any, including yours, actually, you will see that the ALT has an upward, cutoff point of around 30. The same for the AST. My question to you is: what are these enzymes? What are the functions of these enzymes in the blood? What are they doing? Recycling. If you get the answer to that, I will pass you actually, and I can do that. I will actually divulge one of the question of the exam to you. How about that? Is that good enough? Wow! All of a sudden, everybody came back to life. Wow! So, my question to you is: what is the AST and the ALT are doing in the blood? Okay, and we'll do it one-on-one. You don't need to do it here because then you will lose the grade, right? So you will come and tell me in the office, this is what it is. And if it is true, I promise you I will pass you on the question. All right, so now we go back to all right, so we're talking about hepatitis. Starting with viral hepatitis. This is the most feared kind of hepatitis around, especially when it is of a unique form, as we will see. Now, there is what you call hepatotropic virus and non-hepatotropic viruses. The liver could be involved by either one of those. So let's talk about non-hepatotropic viruses such as the CMV, EBV, herpes, and adenovirus, and HIV. So in this case, you will see that the virus is going to be, is going to be caught in the crosshair, if you will, in the crossfire of this process. But the virus itself does not really have any, excuse me. Excuse me. Yes. All right, so it's not really with the non-hepatotropic viruses. In this case, the virus itself does not have any affinity to the liver tissue, as opposed to what you see with hepatotropic virus, where the main inflammation is happening in liver tissue. It does not happen anywhere else. Okay, and the hepatotropic viruses examples are A, B, C, D, E, and G. We are, I think, down to G now. Probably there are more in the work. Now, the morphology of viral hepatitis, as I mentioned to you, portal hepatitis is what you find mainly in chronic hepatitis, whereas portal hepatitis or portal triaditis is what you find in acute hepatitis. I take that back. Now, when it spills over and goes into the lobule and becomes actually established in the lobule, when you start to see a lobular inflammation, that's what you see with chronic hepatitis. But there is a lot of overlap, as I mentioned to you. All right, so chronic hepatitis, portal inflammation, and destruction of the limiting plate, because now the cells have crossed over, the inflammatory cells have crossed over the limiting plate and are now in the lobule. All right, so now in order for you to reach actually a diagnosis of, of what type of hepatitis is happening to the patient, you need to look at the serology of the patient, in terms of infections, that is infectious hepatitis, infectious viral hepatitis. You need to look at the serology of the patient, because those infections are going to arise an immune response in the patient in the form of antibodies. Now, those antibodies could be neutralizing or not neutralizing. Okay, hepatitis C is known actually to result in the formation of non-neutralizing antibodies. Hepatitis B, on the other hand, it's a murky picture, as we will see. Now, so that's just one part of it. Then you also may have to do a biopsy and look at the morphologic features that are going to be there. Now, luckily, nowadays we have the PCR test. The PCR test is going to give you if there is an infection, if there is a viral infection in 100%, of the cases. There is no like shady areas, with PCRs, unless you have the dream team, like what happened in O.J. Simpson trial. All right, good. At least someone can appreciate actually an American joke. All right, so hepatitis A, in this case, it's a self-limiting infection. It comes with the food, so it's fecal oral, right? And it all goes back actually to the fact that so few of you, or so few of really everybody, cook these days, right? At the end of the day, like you are at the whim, of the cook and of the food handler. How cleanly they are. And if you remember, in the US they get paid like what? I mean, $10 an hour. I would be very worried about what I'm putting in my mouth, if you ask me. All right, so it is infectious. So you have A and E, very similar kind of transmission, fecal oral route. And it gets actually to the liver through the GI, and it has a 1 month incubation period. The viremia that accompanies hepatitis A is very transient. And as a result of that, there is no chronic, there is not going to be any chronic phase of the disease. And if someone actually is infected with hepatitis A, believe it or not, when you go to, donate your blood, in a lot of places, they will not ask you, as when it comes to blood donation, it's two tier of testing. One is a behavioral survey, and the second one is lab results. In the behavioral survey, they will not actually ask you about that. And in the lab test, they don't do, the antibodies for the hepatitis A because of this fact right here, because it is transient viremia, very negligible in the course of the disease. Now, if you have pandemic on the other hand, or if you have an epidemic of hepatitis A, then probably that's going to be different, and you will be asked and you will be tested for those kind of diseases, because the chances of someone having it is going to increase substantially. So remember, there is no chronic course or chronic phase of hepatitis A, luckily. It's a RNA virus. It's a single-stranded RNA virus and reaches the liver from the GI, replicates in the hepatocytes. Now, that's actually may cause some injury, but the main injury that happened is going to accompany the inflammatory response that is going to be mounted against those virally infected cells, eventually killing them. All right, so how would you be able to diagnose hepatitis A? By looking at the IgM antibodies. IgM will always foretell that this is a recent infection. IgG is the remote infection. Now, unfortunately, in some instances, not very rare instances, you see that the same infection may elicit IgM and IgG at the same time. Can you remember any infection that you may have studied in microbiology that may do the same, or immunology, that may have actually both IgG and IgM at the same time? No. No. Toxoplasmosis, remember that. Toxoplasmosis. Who does toxoplasmosis affect the most? No, like who is actually significantly cat? Absolutely. Pregnant female. So this is why when you do a testing for those patients who have toxoplasmosis, and IgG is only suggestive, actually. You need to do further tests to look at the pathogen itself, because IgG could actually have IgM as well with it, that maybe actually have, duck below the threshold of testing, or the threshold of detection. And as a result of that, you will not be able to assess it or to realize that it is there, whereas the patient may be having actually an acute infection rather than a remote infection. All right, so measures of prevention. Fecal oral route, how about that? The first thing you need to do, clean your hands, right? That's number one and number 100. But there is also, after an exposure to a person who is infected with hepatitis A, there is, the chance that you may give them immunoglobulin, shortly after infection, high risk for infection, or shortly after infection, after exposure to the virus. I'm sorry, that is. Now, you will see also that administration of the vaccine may also happen before exposure, before travel to endemic regions, or very early after exposure, very, shortly after the exposure happened. So immunoglobulin and the inactivated vaccine. And when it comes to microscopic, you will see actually the portal, because it is an acute periportal and may also spills over into lobular region. The plasma cells predominate. There's variable cholestasis. When does hepatitis A becomes a problem? So hepatitis A, for the most part, is a self-limiting disease. It can hurt a lot, but at the end of the day, the patient is going to resolve this infection completely. It becomes a problem when the patient has another actually chronic liver disease of any type. Let's say chronic hemochromatosis. Let's say chronic hepatitis B or C. Let's say, Wilson's disease, alpha-1 antitrypsin deficiency disease affecting the liver. Any kind of chronic liver disease where there is compensation. So the patient is doing fine. The liver has so much reserve capacity that the liver can take so much and be able actually to work, with minimum really requirements until an infection comes on top of this, compensated state in the form of hepatitis A. And, that's going to take the patient into decompensation and liver failure and death. So what do you do in this case? For someone who have chronic liver disease, let's say, chronic hemochromatosis or hemochromatosis. you go and vaccinate against everything that you have vaccination for, right? In this case, you will vaccinate them against hepatitis A, and you will vaccinate them against hepatitis B. Let's say that your patient is a chronic Hep B patient. What do? In this case, you are going to vaccinate them against hepatitis A and make sure they are following all the precautions, for hepatitis C when it comes to IV drug abuse, sexual behavior, and so on and so forth. Okay. So you guys got an idea, right? All right. All right. So hepatitis B now. Hepatitis B, even after the implementation of vaccination on a global scale, hepatitis B currently actually claims to its credit 300 to 350 million people worldwide who are carriers of the disease. As a result of the advent of the molecular techniques of diagnosis of viruses, especially of Hep B and Hep C, even actually the notion of a cure from hepatitis B is being challenged, because now we know that a lot of instances we test for the antigens and the antibodies of hepatitis B, and there are none of it in the blood. You even actually may be testing the blood of the patient for hepatitis B with a PCR, believe it or not. But the viral load is so small in the blood that your test will come back negative. Where do you think the liver virus is going to be? In the liver, exactly. In the liver. So in this case, you need actually to take a piece of the liver and do a PCR on liver tissue. And as you know, this is an invasive thing. So this is in someone who has, quote unquote, has cleared actually the infection. Those patients, some of those patients have actually developed, let's say someone got infected with hepatitis B and developed surface antibody to the hepatitis B and also core antibodies to the hepatitis B. All right, when you look at this, when you look at these two values, as you will see in the next few slides right here, the lecture is taking me there without me actually doing anything. Okay, you would call that someone who has actually, who has immunity by natural infection, meaning got infected with hepatitis B and developed immunity to the virus. Now, you take that patient and you do PCR on his liver. Unfortunately, there is a chance that his liver may still be harboring hepatitis B particles. And the question mark now is going to be, is this patient at risk of development of long-term complications of hepatitis B in the form of liver failure, cirrhosis, and hepatocellular carcinoma? And new studies are actually coming, to the forefront and are telling us, yes, but not in all the cases, that there is a chance between 20 to 30% of the time that actually those patients may actually go on to develop, the long-term complications of hepatitis B. All right, so as a doctor, especially as doctors now, we're talking about residency, who's going into residencies, especially in like places that are known to be actually harboring this infection. You need to be very, careful about, how you deal with your patients. You need to make sure that one of the most important thing of, of transmission, which is going to be nicking your finger with a needle, right? If there is 3 infections on a needle and you nick your finger on a needle peck, so to speak, which of the following is most likely to be transmitted? Hepatitis B, hepatitis C, or HIV? B. So this is B number 1, followed by C, HIV. Excellent. Very good. And what are the percentage of this? Do you guys know?
Like 90%.
No, not 90. God forbid, not even that. Not even 15, if I recall correctly. 15, 5, 0.5. 15% hepatitis B. And correct me if I'm wrong, please, because numbers, I'm not really a numbers man. 15% with hepatitis B, 5% with Hep C, and 0.5% with HIV. You may want to check that and let me know. What are the modes of transmission? Sexual contact, IV drug abuse are actually right there. So more homosexual than heterosexual contact in the US, and more infected female than males as well. Now, if you look at this beautiful graph, you're going to be getting actually something very interesting. And that is that the majority, as horrible as hepatitis B is, the vast majority of cases actually are going to end up. Can you please help me out with this, because it's still moving on its own. All right. So the vast majority of 60 to 65% are going to end up in subclinical disease, and 20 to 25% with acute hepatitis. Now, the majority of those two categories are going to end up with full recovery. Okay, so if anybody asks, what is the likelihood of developing chronic hepatitis with hepatitis B, it's very, very slim. Now, again, that's different than finding the virus or not finding the virus, because actually you may find the virus, but the patient does not have the disease. So the question will be, what is hepatitis? Hepatitis should have actually lab values, should have clinical actually kind of presentation that your patient is going to be presenting with, okay? And, in those patients, you will see that in hepatitis B, even if they harbor the virus, it's going to be 100% recovery for those, patients with subclinical and acute hepatitis. Only in about 5 to 10% of the time, you have the healthy carrier. Healthy carrier, because for a long time, there has been a debate about if there is any such thing as healthy carrier when it comes to hepatitis B. Now, in about 4% of the time, that's when you start to see the chronic infection. Still, the majority of those patients who go into chronic infections are going to recover completely from the virus, and about 1/3 to 1/10 of the times they are going to develop chronic hepatitis, and that's where you see cirrhosis, hepatocellular carcinoma, and death. So now, if you look at this actually graph, the question that should come to mind, with so little cases, so few cases, very small percentage, 4% of the cases will go on to develop chronic hepatitis. What should that tell you about the rate of infection with hepatitis B? Through the stratosphere, right? So there's a lot of infection. This is why you're ending up with almost 500 million people who are carrying actually hepatitis B, isn't it? You guys get that, what I'm saying? It's a matter of odds, really. All right, so here's some exercises for you, and I usually ask about that in the exam. So let's say that someone comes to you, you do the testing, and the surface antigen is negative. The core antibodies are negative, and the surface antibodies are negative. What do you call that patient? You call it a healthy or a virgin patient, right? He never was exposed to the virus. He never received the vaccine. Now, when you see the surface antigen negative, the core antibodies positive, and the surface antibodies positive, the fact that you have actually negative surface antigen and positive surface antibodies with a core antibody that is positive, you call that person to have actually gotten the infection, but have actually developed immunity as a result of that infection. Okay? Now, hepatitis, the reason why, I mentioned to you PCR, and I'm talking about antibodies and antigens here. The reason for this is, depending on where you go in the world, you will see different countries do different techniques in order to ascertain if someone has the infection or not. So you, better know both actually ways. All right, so surface antigen that is negative, core antibody that is negative, and surface antibodies that is positive. When you see this actually profile, that this patient has immunity by vaccination. And the reason why is that the case, because when you do vaccinate for hepatitis B, you're giving the patient a recombinant HBsAg. You're giving the patient the capsule of the hepatitis B that is made in a lab. It's not the infectious capsule, God forbid. Okay. And as a result of that, the patient is going to develop only surface antibodies. But you did not expose the patient to any actually component of the genome of the virus. So as a result of that, the patient or the person will not develop any antibodies to the core, to the genome of the virus. Okay, did you guys get that? Did you get that?
Yes.
All right, good. All right, so now coming to a little bit more complicated. Just one thing actually to keep in mind, the definition of chronic hepatitis following hepatitis B infection is the presence of hepatitis B surface antigen more than 6 months following the infection in the serum of the patient. So the lingering, the non-clearance of hepatitis B surface antigen in the blood of the patient, in the serum of the patient, 6 months after the onset of the hepatitis B infection is the definition of chronic hepatitis B. Okay? So in this case, but the question will always be when you have a case like this to ask yourself, how long did the person have actually the surface antigen? The patient may be actually 1 month post-infection. Do you call him chronic hepatitis? You don't call him chronic hepatitis. That's right. You need to wait until 6 months to see, has it been cleared? If it's cleared, you don't call him chronic hepatitis anymore. If it is still there, you call it chronic hepatitis. So duration is also very important. So this person has hepatitis B surface antigen positive and has a core antibodies that is positive. Once you have core, you have to do something known as fractionation, because you want to know if the core antibody are actually due to IgG or to IgM. Okay? They did the fractionation, and it turned out that this is actually an IgM core antibodies that are positive. You do the surface antibodies, and it is negative. Okay? Now, what is that patient? Let me ask you this in another way, because here you have what is the duration of this infection? Probably less than 6 months. Excellent. So it is less than 6 months because this guy still have the surface antigen, have the IgM core antibody, which is recent, right? And has not developed the surface antibodies. So this is a recent infection, acutely infected. Okay, let's do the last one. The surface antigen is positive, the core antibody is positive, the IgM to the core is negative. So that means that the fractionation result is where now? It's the IgG, excellent. So it is the IgG that is positive, and the surface, lo and behold, is actually negative. So what is that? More than 6 months. Because if it was actually, it's more than 6 months for the reason is that this is an IgG, okay, core antibodies, and the surface antibodies are not there yet, okay? And as a result of that, this patient is going to be chronically infected. Does that mean that this patient will never clear actually the hepatitis B surface antigen? The answer to that is no. There are actually, chances, there are actually, there's a likelihood, regardless of how small, that this actually may be cleared at one point in time as a result of a brisk immune response that is going to bring everything, back to normal, clear out the surface antigen, and, develop antibodies, full surface antibodies to this virus. Okay? All right, so when you do microscopic examination of hepatitis B, you're going to be seeing actually this is a chronic inflammation. So you will see mostly portal, inflammation, in addition to others, as I mentioned to you. You see also varying degrees of fibrosis because it does not resolve completely and without any trace. And steatosis is not a feature, whereas it is a feature with hepatitis C. But that's a very weak sign because, for example, let's say someone is having fatty liver who got infected with hepatitis B. So with those patients, you will see that they will have actually steatotic features, of infiltration of liver cells. Here's an example of that. So this is what you see, what you call actually a ground glass cytoplasm. What's the ground glass cytoplasm? These are the HBS, this is the capsules of the hepatitis B that are being made, created, sensitized in the liver cell. So as I mentioned to you, the hepatitis B virus is going actually to get into the liver cell and will take over the genome of the cell to start actually to make particles of its own. So it will start to make genome of its own. It will start to make capsule of its own to create, viral, offsprings, if you will. At one point in time, when this cell becomes so inspissated with this growing viral particles, it's going to burst and die out completely. Now, if you have any doubt about what you have, we have actually a surface antigen immunostain. So you take a biopsy and you put it on this, you stain this section with it, and it will come out as positive for hepatitis surface antigen. Here's an example of the effects of hepatitis B viral infection on the liver. One of them is going to be the apoptosis. We have seen why apoptosis happen in the liver. Why does it happen in the liver? Resulting from what?
Immune cell.
Which cell?
Fibroblast.
CD8 T cell. And how does it do it? This is from POD, man. CD8 T cell, what does it do? Perforin. So perforin, okay. All right, perforin. And what does perforin do? It will perforate the mitochondria, right?
Yeah.
And will release the cytochrome C, will kickstart actually the apoptosis process. So this is actually resulting from the immune response to the virally infected hepatocyte, what you call apoptotic cell, known also as Councilman bodies. So what's a Councilman body? It's simply an apoptotic virally infected liver cell. Here's another one. Actually, this is ballooning degeneration, and the ballooning, why it's happening? Because of the proliferation of the viral particles inside the liver cell. All right, now hepatitis C viral infection. This is a completely different animal. For a long time, we did not really know that there is actually, another viral infection that is, making the rounds. So until they figured out that there is something else that is not A and is not B that is causing the infection, that was in the late 1980s, long before you guys were born, and early 1990s, they started calling it non-A, non-B. And, the genius of American medicine is that they started actually to look at it after a lot of epidemiologic studies. They started seeing that, in patients who have non-A, non-B, there is, the core antibodies to hepatitis B are coming out as positive. So positive core antibodies, the IgG core antibodies to hepatitis B. And they also found out that actually ALT is also raised in those patients with non-A, non-B. So those two tests were the tests that were used to actually, believe it or not, diagnose patients with hepatitis C until they were able to do the ELISA test and look at the antibodies that are created by the virus. That was followed shortly thereafter with the PCR that looked at the exact actually viral and particles itself. So for a long time, it was non-A, non-B. Now, this is a completely different animal than hepatitis B, because the majority of patients with hepatitis C will go on to develop chronic hepatitis, okay? So the vast majority of hepatitis B patients are going actually to clear the virus, whereas the vast majority of chronic hepatitis C patients are going to go on to develop chronic hepatitis. And the reason why is that the case? Because the antibodies of the hepatitis C are non-neutralizing antibodies. The reason for this are two parts of the genome of this RNA virus. The first part is actually the RNA-dependent RNA polymerase. This is an enzyme that is entrusted in making, the genome of the virus, of the RNA virus. Now, it is what you call a poor fidelity kind of enzyme. Poor fidelity because it has what you call poor proofreading ability. Poor proofreading ability, meaning when it starts to actually transcribes, from the mother, sequence, it will start to create a lot of variants that have mistakes in them. The majority of those, RNA, strands are going to be simply, will simply wash away, will simply die. They will not result in anything that is going to live. Some of them may live out to become actually, fully integrated, virus. As a result of that, you will see that if you go and survey any hepatitis C patient at any point in time, you will see that in the serum of those patients, they have several variants that remotely resemble the original mother strand. And where do they come from? They come from the poor fidelity of the RNA-dependent RNA polymerase. And how is that going to result in hypervariable regions of the E1 and E2? So as a result of these two actually, important points to be made about the genome of the RNA virus that is hepatitis C, one, you will have actually chronic infection with higher likelihood than hepatitis B. The reason for this is that the antibodies that are being made for the original infection are non-neutralizing antibodies. Why? Because the viral particles that are coming out as a result of the work of this proof-reading ability enzyme are not going to resemble the mother, ship, if you will. And as a result of that, you will see that those antibodies will be non-neutralizing. This is similar to actually what you see if you think about it. They call it in books, it's in a way, actually, it's probably a mistake. But if you really think about it, the hepatitis C virus in this case is doing what an Air Force pilot will do when it releases the decoys. Probably the guys would be more interested in this, releasing the decoys, and you're shooting them with this surface to air missile, right? Where will the SAM go? It will go after the decoy. It will not go after the original plane, right? That's exactly the case here, is that the virus will create many variants of itself to mislead the immune response and, run away, creating actually, more damage to the liver tissue. So this is one. Two, because of the fact, of the hypervariable region of the genome particularly of the envelope protein part of the genome of the RNA sequence, the end result of that is going to be there is no likelihood of developing vaccine. Now, this may actually be different now with the new methodology that they are creating vaccines with, but as of now, there is no vaccine for hepatitis C. This is the same actually of what we have discussed now. All right, acute infections are asymptomatic but different than HPV, no recovery, and the RNA. You can read that on your own. Risk factors, the same exact risk factors that you see with hepatitis B. So again, it's IV, drug abusers, homosexual contact, needle stick in healthcare workers, and acupuncture. We talked that it is actually it is going to be less likely than Hep B, but more likely than hepatitis B, than HIV. I'm sorry, than HIV. Perinatal infection less likely than hepatitis B. Very unlikely to happen, but it may happen with perinatal infection. Blood transfusion, that used to be the norm actually of the transmission before the ELISA and before the PCR. So this is, there was actually a number of scandals that resulted from this, transfusion of tainted products with hepatitis C that happened in the 1980s and 90s, long time before you guys were born. Reason for sporadic, you need to know that. Okay, so look at this beautiful graph here. Again, if you look here, you will see that the vast majority of cases of hepatitis C is going to end up with chronic hepatitis. And the vast majority of those cases are going to end up with chronic hepatitis, but with stable disease. And in 20% of the time, there's cirrhosis, likelihood of actually death, and before that, hepatocellular carcinoma. Now, stable disease, if you ask me, there should be probably, an arrow that should go from stable disease to cirrhosis, okay, and to death probably, because again, it's, once you have this kind of infection, anything can actually, any kind of immunosuppression, in the patient, it could be a transient immunosuppression from another disease the patient is having, may open the door of an activation of this disease that may put the patient in a very, nasty place. All right, so what are the morphological features? One of the morphologic features that is probably more consistent than the rest is going to be the lymphoid follicles that you see with hepatitis C. There is also some bile duct damage by the lymphocytes, but it does not result in ductopenia, such as what you see with sclerosing cholangitis and biliary cirrhosis, primary biliary cirrhosis. And also macrovesicular steatosis is common, but again, imagine, what the value of this will be in a patient who already have fatty liver. That is going to negate its value as well. So, and most importantly, is going to be serology in this patient. ELISA, you do ELISA to just see if the antibodies are there or not. The antibodies are not actually neutralizing. A biopsy like this is suggestive of hepatitis C because of the fact that you have what looks like a organizing lymphoid follicles. Yes? No, it's not. All right, in 6 minutes. 6 minutes, guys. 6 minutes and we'll be done. All right, so this is lymphoid follicle, suggestive again of hepatitis C. Now, what do? There is something called qualitative testing. So PCR qualitative testing that will tell you if the patient is having the infection or not. Once you do that and you are certain that the patient is having that infection, you do the qualitative testing. That is the viral load. That is going to tell you actually how the patient is doing in response to treatment. So quantitative versus qualitative. Qualitative is to confirm to you if the patient is having the infection or not. Quantitative is how much of the infection does he have. And as you know, there is a new medications. You guys are going to discuss that with Dr. Abou El Khail. That is really doing the rounds. It's a great news for a lot of countries that unfortunately, some of them are countries that are affected with hepatitis C. These medications are actually fixing the virus, taking care of it, fair and square, which is important. You will also study with Dr. Abou El Khail the genotype of the virus. I will leave that to him. And, we did mention actually that you need to follow up the patient with liver function test, looking at each facet of liver functions. Complications, the complications already. Hepatitis Delta, this is what you call a disabled virus. Hepatitis Delta on its own will never cause infection. It will cause infection only in one of two conditions. One is a co-infection with hepatitis B, or actually superimposed on hepatitis B. The reason for this is that hepatitis Delta needs actually the surface antigen, it needs the coat, and it needs also the genome of the hepatitis B virus for it to replicate and to produce a viable virus. So it can only cause this kind of infection, hepatitis Delta infection, if you have hepatitis infection, either concurrently or remote. All right. So there are actually two scenarios when it comes to this. In the case of co-infection, both of them, let's say someone is lucky and he got one of the ways that the virus can be transmitted. One of them is going to be, again, the IV drug abuse, the sexual contacts, blood transfusion, which is very remote, as we have talked. But let's say somehow, this patient was exposed to someone who have both actually hepatitis B and hepatitis Delta viral in their blood. So this is what you call co-infection. In this case, the two viruses are going to compete with each other, on the viral components. They will compete on the hepatitis B surface antigen, and they will compete on the genome of the virus. And as a result of that, both viruses are going to be weakened. And there is a good chance, actually, much more likely that, with the co-infection, that the immune system of the person who got infected will be able to clear both infections at the same time. Whereas if someone is already infected with hepatitis B, and then the person got exposed to someone who have the hepatitis delta infection, in this case, the B infection is already established. So in this case, there's a chance that the patient may actually have accelerated chronic hepatitis with delta and B, and eventually end up in cirrhosis in a very synergistic kind of way, in a much shorter period of time and much more complicated path than someone who have, the hepatitis B viral infection only. All right, so how about this? 40% in Africa and the Middle East. Okay, that's pretty high, right? So serology, IgM, is going to tell you if you have a recent infection. That's the most important test in this case. Will tell you if you have a recent, hepatitis delta viral infection or exposure. With acute co-infection, you will look at actually the two IgM. So the IgM of delta and the IgM of the B virus, but also you will see the core antigen that is going to be there in the blood as well. With the chronic delta hepatitis, remember the hepatitis B surface antigen is already there, okay? And you will find out that the patient is having the IgM and the IgG in low titers for months or longer. All right, let's stop here. We'll continue this some other time. I closed it. Is that a problem? Is that okay? You sure? Okay.